So firstly, we will go through the 10 OSCEs. So firstly, we will go through the 10 OSCEs. So first one is identify this image and grade the hemorrhage. You can start writing in the chat box. So grade 4, grade 4, grade 3, grade 3. Okay. Another second question. What are the types of clinical presentation in IVH? Silent and saltatory. Okay. One more remaining in that. There are 3 clinical presentations. Catastrophic, right. Third, any 2 perinatal interventions that can prevent IVH occurrence in preterms. Okay, steroids. Perinatal, not gentle suctioning. Okay, steroids. Okay, what are the vascular factors involved in pathogenesis of IVH? Why IVH happens mostly in preterm babies? Vascular factors, intra and extravascular is there. What are the vascular factors? Okay. So this is not grade 4 IVH. This is grade 3 IVH. We should see IVH in coronal, but quantify in our sagittal. Okay, so this is filling the ventricles more than 50%, and there is some dilatation. So this is grade 3. No, why it's not moving? So this is grade 3 IVH as per Volpe. So there are 3 grades and with spatial notion, right? So in grade 1, there will be only germinal matrix or less than 10% of intraventricular hemorrhage. In grade 2, there will be 10 to 50% of intraventricular hemorrhage, but there will be no dilatation. And in grade 3, there will be more than 50% of the intraventricular hemorrhage, and there will be dilated ventricles. So all this has to be quantified in the parasagittal view only. So there are 3 types of clinical presentation. One in catastrophe, that is rare, but very dangerous. Second is saltatory, and third is clinically silent, that is more common. So clinically silent, like baby may not have much more clinical features except from the anemias like that. Another is saltatory. In that, baby will have features that can be very rapid from the hours to days and have neurological features like altered level of consciousness, and there will decrease motility, hypotonia can be there, and there will be increased increased tightness in the popliteal angle. And respiratory disturbances like respiratory distress can happen in saltatory clinical syndrome of IVH. And when it progresses to catastrophic, it can be within minutes to hours, and the baby can progress from the stupor to coma, and from the respiratory distress to apneas. There can be generalized tonic seizures, and there can be decerebrate posturing also. And there can be facet quadriparesis also. So how we will prevent? The 2 most common are the delayed cord clamping and the antenatal steroids. Antenatal steroids has been proved to decrease IVH incidence. Okay, both the total and the severe intraventricular hemorrhage incidence. If also the cystic periventricle leukomalacia also. The mechanism is not yet established, but probably by improving the cerebral hemodynamics and maturation of the vasculature. So these are the other some perinatal interventions that can reduce the germinal matrix hemorrhage, like prevention of preterm birth, transportation in utero, and prenatal pharmacologicals like glucocorticoids, like antenatal steroids, and vitamin K and Maxils, and optimal management during labor and delivery, like proper positioning, delivery of the proper CPAP and all, and delaying of the umbilical cord, temperature stability, and proper take care at the newborn resuscitation table. So pathogen, we were discussing about the vascular factors. There can be intravascular, there can be extravascular, and there can be vascular factors. So vascular factors will be like, because the capillary integrity is not well in this kind of babies, they are very tenuous, and they are involuting, and there is very thin lining of the vasculature. So they are very prone for IVH. So moving to second OSCE, what is this instrument and for what it is used? You can see the screen properly, that machine, yeah, apnea monitor. So this is apnea monitor. So how does it work? Mhm. How apnea monitors work usually? What is the basis of their working? Okay, impedance. But in this, there is something, no, we can see here something boot like, which will be, yeah, vibrates. Yeah. So when the bradycardia or desaturation happens, it will detect, and here it will sense and it will start vibrating, flickering the baby's soul, and then thus stimulating the baby. Right, very nice. What pharmacological treatment are used to treat this condition? What drugs you will use to treat apnea? Caffeine, yes, yes, yes. Which is better, caffeine or theophylline? Okay. Why caffeine is better than theophylline? Yes. Better therapeutic window than the theophylline. Okay. Any role of non-invasive respiratory support in apnea management? How does it help in preventing apneas? How non-invasive support help in preventing apneas? Okay. Splinting, laryngeal reflex. Okay. Splinting airways, laryngeal, and by giving FRC. Okay, fine. Uh, this apnea boot is using vibrator mechanism. What other technology is being used? That we have already answered, I think. Impedance. And when we are using impedance technology, apnea monitors, what is the limitation of that? Which type of apnea can't be detected with impedance monitors? No, not central. Obstructive. Yes, because there will be movement, but there will be no flow. So it is not going to detect your obstructive apneas. Very nice. So we'll just run through the answers. So this is apnea boot. This is used in neonatal respiratory monitor for apnea resolver. It identifies apnea by inbuilt pulse oximetry and vibrates by and thereby auto-stimulating the foot sole of the baby if the baby develops apnea. So drugs used in the treatment of apneas are caffeine, theophylline, and doxapram in case of resistance to not responding apnea to caffeines. How does the non-invasive respiratory support works? By splinting up the upper airway and increasing the FRC. And impedance monitors don't detect obstructive apneas. So what does this diagram represent during the ventilator strategy? What this strategy is known as, which is being depicted by this diagram? Recruitment. Open lung ventilation strategies. This diagram depicts the open lung one. Okay. In this, which point is depicting the closing opening pressure and which is depicting the closing pressure? No, A is not the opening pressure. Not E is also not the closing pressure. Closing pressure as C is right. Opening pressure is depicted by which point? Okay, we will learn now. Next question regarding that is, which conditions will be treated well using this kind of strategy? This open lung strategy when you are going to use, okay, MAS, RDS. Okay, any parenchymal lung disease, it's better to use open lung strategy. Okay, in which condition this is not helpful? No, pneumonia we will use, yeah, CDH. CDH in this strategy will not be useful because there will be pulmonary hypoplasias. Okay, so this diagram, this bit pressure time diagram, in this, at this point, there is resting. The alveoli are in resting phase. We are going to increase pressure. P mean we are going to increase and we are going to open the lungs. And at this point, the lungs will be maximally open. The P max will be reached. And at this point, the FiO2 will be less than 30%. More than beyond that, if you increase, the FiO2 requirement will increase. So, and if you start decreasing also, the FiO2 requirement will start increasing. So at this point, there will be closing pressure. So you have to work between these two. So above 2 centimeters above the closing pressure, you have to use your operational pressure. So this E is your operational pressure, right? So this is open lung strategy. Point B is the opening pressure. C is the closing pressure. Parenchymal lung disease, we are going to use this open lung strategy. And in congenital diaphragmatic hernia, it is not much helpful because of the lung hypoplasia. There will be, we will be giving more P mean and whatever, more than whatever is necessary, causing thereby leading to the pneumothorax, and there will be no improvement in the oxygenation also. So in those cases, we have to use gentle and lung protective strategies. Okay, so this is an echo showing some flows. In the plaques view, we can see there is right ventricular inflow. In the parasternal short axis view, we can see there is some ductal flow. And in the apical four-chamber view, we can see atrium and there is flow across the PFO, right? So what is the condition is being depicted in this view? Yes, PPH and TR jet is there. So what is the etiology of this condition? What predisposes newborns to have PPHN? Okay, mass. Any other disease? RDS, okay. Okay. CDH, okay, fine. So, clinical cues to identify this condition. How clinically you will diagnose this case that, okay, baby maybe having PPHN, labile saturations, differentials in SpO2, bounding pulse, pre and post ductal difference, increase in FiO2 requirement, differential cyanosis, okay. Okay, fair enough. Anything in the auscultation? Okay. Okay, fine. TR murmur will be there. So, in any three echocardiographic finding that you are going to get in the case of PPHN? TR jet. Okay. What more? TR jet can be there in multiple stuffs. Okay, ventricle. Okay, okay, okay. So only two has still come up. More to go. TR jet and septum deviation. Okay. Okay, how are you going to manage this case of PPHN? First line management. Okay, INO, sildenafil. Right away you will start INO, sildenafil, or before that you are going to do something. How you are going to give oxygen? Proper ventilation. By proper ventilation, you mean? Okay, lung recruitment, right? Minimal handling, customer care, sedation, INO, and sildenafil. Fair enough. So we will just run through the answers. So this is the case of PPHN predisposed by, it can be idiopathic also or can be predisposed by the lung parenchymal diseases like RDS, MAS, CDH, anything can predispose it. Clinical clues are labile saturations, differential cyanosis, degree of hypoxemia that will be disproportionately high as compared to the parenchymal disease. There will pre-post ductal SpO2 difference will be there, more than 5% around. And on auscultation, there will be prominent precordial pulse and narrow split and accentuated S2 and harsh systolic murmur of TR. So on echo, if we see for the pulmonary pressure determination, the TR peak velocity, we are going to check for the pulmonary arterial pressures and IVS configuration we are going to do. And the ductal flow we are going to see. Shunting around the PFO and PDA we are going to see. And we are going to check for the pulmonary vascular resistance with the help of PAT. Okay. And the right myocardial performance, how we are going to check by the ventricular systolic function, that is by the fractional shortening and the eyeballing, and by checking about the TAPSE, right? And management, everyone has clearly told. Okay. Read this ECG. And what is the enormity you are getting in it? No, it's not PSVT. No, it's not RBB. You can read through the further questions also, then you can get the clue. Right, this is congenital heart block. Okay. So what causes congenital heart block? Okay, SLE mother is there. Other causes of congenital heart block. What syndromic associations? Rheumatic heart disease. Babies will have rheumatic heart disease. Connective beta blockers, stuff. No, no, no. Some CHDs. Yeah, CHD. What CHDs? Okay, TGA. That which TGA? DTGA, LTGA. Which kind of TGA? No, it's not DTGA. It's mostly with the CCTGA. Yeah. Okay. How you will do ECG in a fetus? Mm-hmm. Yeah, invasive and non-invasive fetal ECG we can do, or we can use Doppler ultrasounds also. Okay. So medications that can be given in the antenatal period that will probably help in preventing the progression of this disease. Hydroquinone, okay. Mm-hmm. Right away we are going to give sotalol, methylxanthine Y, antenatal IVIG, okay, fine. Steroids, okay. Antenatal IVIG. Okay. And in the postnatal period, what one can give? Postnatal management of this baby. Pacemaker. Right away, you are going to do pacemaker in this baby. Atropine is not going to help much. No digoxin. Okay. Okay, we will go through the answers now. Isoprenaline, right. So this is the case of complete heart block, and causes are, one is the maternal lupus, SSA, SSB antibodies, and heart diseases like abnormalities involving the AV node, that is CCTGA or AV canal defect or DORV conditions, and in channelopathies like long QT syndrome. So methods we have already discussed: fetal, non-invasive, invasive, and Doppler ultrasounds we can do. In fetal management, this steroids and IVIG can be used in case of maternal lupus. And in case of channelopathies, we have to just monitor and we have to prevent the mother having any electrolyte anomalies, especially the magnesiums and all. So even if the baby heart rate is less than 55 beats per minute, fetus heart rate, so we can give beta agonist to the mother like terbutaline, and fetal pacing can be tried in case of refractory bradycardia. So in postnatal management, drugs used are isoprenaline, that is given IV. And if the baby is being discharged and baby is hemodynamically stable, we can discharge baby on oxyprenaline, that is the oral form of isoprenaline. And if the baby is symptomatic or if the heart rate is less than 50 per minute, so we can plan pacemaker. So moving to sixth OSCE, read this lung biopsy of a 60-day-old neonate, which was born at 28 weeks of gestation and required respiratory support for 28 days. So this is the lung biopsy of an 28-week baby on respiratory support for 28 days. Answers are already coming up. Okay, BPD. So what is the risk factor for this condition? Antenatal, postnatal risk factors, name few. Lack of steroids, very nice. Okay, invasive, prolonged ventilation, okay. What more in antenatal that can predispose this baby? One is lack of antenatal steroids. Name something fuel, some infection in the mother that can predispose the baby for BPD. PPRM causing what? What PPRM is going to cause? Chorioamnitis, right? Okay. And postnatally, sepsis, aggressive ventilation. Okay, fine. So, what is the recent classification for this condition? Okay, okay, fair enough. Uh, so, evidence-based measures to prevent this condition? Steroids, right? Lisa, caffeine, fine, very good. Steroids with steroids, Diraton, CPAP, okay. Caffeine. Mm-hmm. Okay. Okay. And long-term complications of BPD children? Mm-hmm. PPHN, okay. Neurodisability, chronic lung disease, okay. Okay. Fine. So moving to answers. So this is a case of new BPD because there will not be much inflammation. There is arrest of the lung development. So antenatally, we have already discussed there will be chorioamnitis, lack of AN steroids and FGR. And postnatally, aggressive ventilation, oxygen toxicity, and PDA sepsis are predisposed. And so there is a new classification, and we have already discussed all those. So we will move on to the seventh OSCE. So what is this? What is this instrument and what it says use? Surf cat and Lisa. It's not Lisa tube, it's surf cat. Okay. So name some few methods, like some few methods for Lisa. Do you know any methods name? No, ensure missed. No, not that. Lisa and missed people. Yeah, Hobart method, right? Very nice. Few name others. Okay, Cologne. Fine. Uh, if we are going to use this technique, Lisa over ensure, what benefits this is going to give? Okay, BPD prevention will be there. Fine. Any other advantages, benefits? Okay, it's non-invasive. So what is going to help? Okay, it is going to prevent ventilation. So thereby it will help in reduction of BPD. Right. What more benefits it is going to give? Lisa over ensure. So less stress to the baby, what it will help in preventing? Okay. Intracranial hemorrhage, intraventricular hemorrhage. Okay, fine. Fair enough. Uh, so during this procedure, what adverse effects one should be vigilant about? Reflux, fine. No, not sepsis. During the procedure, what you are going to see? Reflux is okay. Anything else? Desaturations, right? Bradycardia, okay. Okay, fair enough. So we will move to the answers. So this is SurfCat. This is used for mist. Okay, another method's names are Cologne, Sonosure, Take Care method, Hobart method. It will help in reducing the BPD or death, BPD, severe IVH, and need for mechanical ventilation within 72 hours of life. And the beneficial effects number needed to treat to, okay, this I forgot to ask. NNT to prevent BPD is 13. What is NNT? What is NNT? What do you mean by NNT? Number needed to treat. Okay. So this is 13 in case of BPD and side effects we have seen during procedure. Okay, moving to the next OSCE. Okay, this is a term neonate whose antenatal scans were showing some cystic lesion in the lung. So postnatally, this baby underwent CT scan and this is the CT image. So this is a case of CPAM, right? So what is the most common type of CPAM? Mm, mm-hmm. Okay, type 1 CPAM is the most common. And which type of CPAM is associated with other systemic abnormalities? CCAM2, right. So at birth, what complications you are expecting in this baby when you are going to attend this delivery? What should you should be ready with? Mm-hmm. Asphyxia, gasping. How many babies with CPAM you have seen? Okay, fine. What CPAM is going to do in the fetus? No, why it will require bag and tube? Why asphyxia will be there? What you are expecting in this baby? Why pneumonia? During delivery, during birth. Okay. Mm-hmm. Pulmonary hyperplasia, no. Mm-hmm. No, we are expecting hydrops vitalis. Yeah, we are expecting hydrops vitalis in this case. Right. And baby will have respiratory distress, so we should be prepared for that. Okay. So any antenatal marker you are knowing to predict the severity and prognosis of this baby? How you will prognosticate an antenatal scan for CCAM baby? Like in CDH, we do no LH ratios and all we do. In CCAM, what we are using? No, LH is for CDH. For CCAM, what we usually CVR ratio. Okay, what is CVR? Full form of CVR? Okay. So what CVR cutoff you are going to take as a poor prognosis? No, more than 1.6 CVR is a poor prognostic sign. Okay, so any antenatal fetal interventions you can do to prevent this kind of complications like high drops and all? Exit. Mm-hmm. Anything else? Okay, we will move ahead with the answers. Steroids, okay. Okay, so type 1 is the most common type of CPAM. Type 2 is mostly associated with the systemic anomalies, hydrocephalus and respiratory distress. We are expecting the baby to come out after delivery. CVR is usually used to prognosticate, and antenatal interventions are thoracoamniotic shunt can be placed, antenatal steroid therapy can be done, and fetal thoracotomy and resection can be done. So last but not the least, one before, okay, ninth one. This baby is having congenital hypothyroidism. Okay, what hormones, thyroid hormones usually cross the placenta? Not TSH. TSH doesn't cross placenta. T3 cross, okay. T4 cross. When to screen is after 72 hours, okay. Disadvantage and advantages of using TSH as a primary diagnostic screening. Primary screening, sorry, diagnostic. If you're using TSH only as a test for screening, what are the advantages of using it and what are the disadvantages? Central hypo will be detected or not? Fine. Okay. So diagnostic criteria, one is telling if TSH is more than 9, should repeat after 2 weeks. Anything else? Okay, we will run through the answers. So TRH, T3 and T4 will cross the placenta. TSH doesn't cross the placenta. So either we can do by the cord blood, but better to do after 72 hours of life. Advantage of using TSH only as the screening test is like it can identify all the primary hypothyroidism and it is cost effective. But the disadvantage is it can't detect central hypothyroidism. So diagnostic criteria to identify hypothyroidism from the venous sample is if the free T4 is less than 1.17 nanogram per deciliter irrespective of the TSH, or if the TSH is more than 10 irrespective of the free T4 after 3 weeks. In these two cases, we have to start baby on thyroxine and we should not wait. So last one, what views are depicted in this eco shots? Okay. Plaques and there are two views, no? Plaques and plaques. Okay. So from this, can you make out what is the condition? What these views are showing? Any heart disease, anything specific is being shown? Okay, TGA. So, okay, you have diagnosed TGA. So once you have diagnosed TGA, what kind of shunts you are going to check in this baby? Which shunt is the most important to look into? No, not VSD. PDA is okay, but most important is ASD. Yes. So if your ASD is restrictive, what intervention you are going to take? Okay. Okay, fair enough. Switch is later on. If ASD is restrictive, immediately we have to do for balloon atrial septostomy. Okay. So we are done with our OSCEs.
Yeah, we are done, right, Dr. Ajna?
Yeah, sir. Done, sir.
Yeah, thank you so much, Dr. Ajna, for moderating the case presentation as well as elaborate OSCE. It was very excellent. And thank you all the participants. I hope students would have learned a lot from your session. Thank you so much. And we are closing the session.
Thank you so much, sir, for the opportunity and very fine doing by the students.
Yeah, great. Thank you so much.
Thank you, sir.
Thank you, ma'am. Thank you, sir.
Thank you. Okay.